If you guys don't have anything, I'm just going to hop into this week.
I just had one quick question about something you said at some point last week. It was about shoulder flexion measures, and how typically the side that has more flexion, your pelvis is rotated towards. I think
Mhm.
that's what you mentioned, and I was wondering like a little bit like what would be the mechanics behind that and the reason why that is.
Yeah, so I think taking the left AIC, for example, is a good way to do that. So if you're here, pelvis is rotated right, sacrum is rotated right. So we have to counter rotate up top to go back to the left to even ourselves out. So because of that, we get this right rib hump due to the position. So usually when people bend over, you'll see this right side sit higher. That's because we get more posterior expansion, remember, on that right side, which allows us to then get more overhead flexion because that's more associated with posterior expansion. Does that answer your question?
Yeah, and the lower portion of the rib cage, the posterior aspect, compressed in the left AIC? Because I know there's a rotation that way, but you're also side bent, so the flat is a little bit shorter.
Yeah, I think the left side is going to have more of that compression, right? Because that left erector wants to kick on because it's in more of that concentric orientation. So I'd say the left one is going to be more predisposed to that. But if you get like a bilateral forward pelvis, or if you're more of a wide, for example, then I'd say yes, you're going to have more of a predisposition to have that.
Cool. Thanks.
Hmm. Anything else? We had one question that I think was really good, and I wanted to hit it really quick. It was when you test someone, and let's say they're wide and they have what you would pretty much expect, like a pretty good straight leg raise, hip flexion goes to 90 degrees because they're compressed, but you measure their femoral rotation and it's none, or it's very, very limited. So what's going on there? Well, usually if you measure femoral rotation, think about where the pelvic position is, like this, right? But then you're going to put them in 90 degrees of hip flexion, and then you're going to measure internal rotation from there. So you're kind of already there. And it's really hard to rotate more if you're already pretty much maximizing your compression in your pelvis without doing anything active on top of that. So you're starting in a place of internal rotation. And then because of the hip flexion, and then it's going to be hard for you to further internally rotate from there. So hopefully that clears that up, because what you're really measuring there is the distal femoral internal rotation. You're measuring this moving, but it can't because this is already there. Does that answer your guys' question on that? I can see how that would be confusing. Okay.
Just a quick one, Connor, before you
Yeah.
get going. With a narrow ISA who, so they get poor toe touch, are they compressed? Yeah, I think they're compressed posteriorly in the hips. Is that right?
Yeah, narrows have this thing going on, so that all these external rotators become concentrically oriented in the glutes and things like that. Mm-hmm. So that's why I have trouble nutating, is because they need to let all that go, which they struggle to do. All right, let's rock and roll. Okay, week 5. So what we're going to talk about today is the differences between all these different strategies and how people compensate and how we end up in a compensatory strategy. So there's really 3 main layers. There's the first, secondary, and tertiary. And what's interesting is the further along you get on this, the more similar these two people start to look. So that's why when you see people that are, I don't know if you guys ever watch a Bill Hartman video, he'd say they're in game. Or if you see someone, they're like, you're just, I don't know, PRI might call this like a patho PEC or something like that. These people look very, very similar. And we can look at them and you can just kind of tell right away that they have a lot going on. These are your people that have crazy, crazy looking postures. They're really compressed, hunched over. Perfect example of this is someone who's very, very old and they're relying on their walker to help them. Like that's someone who's probably in game because they're just relying They've been compressed for so long. But you'll see as we progress through this, it's just the starting point is very important, but the end point is very similar. And then we're going to be able to measure and assess pelvic orientations, which is a separate thing from what goes on within these respiratory biases. And then we're going to appreciate the biomechanical presentations of extremity and neck pain. So we can see what is probably going on locally instead of globally at these extremities and also within the neck. Okay, so let's get into the global stuff first, because I think that's just it's good to take sort of this broad lens before we get into the intricate details. So secondary compensations are larger and more superficial. They're closer to the surface. So if we have, for example, a left AIC pattern, that's buried within us as human beings. That's just our genetic makeup. But for example, if that left adductor can't do its job, then you're going to kick on another muscle to help do that job of the left adductor. For example, if your right glute doesn't work, you're going to kick on another muscle to help your right glute. If your right piriformis doesn't work, you're going to kick on your right glute to help you do that. So it's really just what's not working, and then something bigger is going to take over for the lack of function within the smaller muscles. So ultimately, we need to downregulate the tone of the big muscles in order to get to the smaller muscles. It's kind of just like unwinding the layers of compensation. Okay, so we kind of know this already, but I wanted to hit it just to review. The wide is going to be biased towards a nutated sacrum. They're going to have a greater degree of lumbar lordosis and therefore thoracic kyphosis. They're going to have an IR bias at their femurs, and because of this compression they have posteriorly, they're going to have a lot of expansion anteriorly within their ISA especially. So what happens from there? If you guys paid attention to what I said about posterior compression, at this point, let's say for whatever reason, it's hard to pinpoint and say this is what causes it, because there's so many factors in someone's life. Like, what kind of an athlete are they? How much do they sit? What do they do outside of their desk job? How do they train? All these different things influence it. So I can't say like at this moment, this person's going to do this and look exactly like this, because we're all variable. So the general theme here is that this posterior compression is pulling this wide ISA back. So they're like, oh crap, I'm falling too far back. I need to get myself to come forward to manage gravity so I don't fall backwards. So what they're going to do is they're going to compress themselves anteriorly, generally speaking at that sternum level, because that's an easy way for them to collapse down and seek an exhalation strategy, so to speak, because they're too hyperinflated within that anterior rib cage. But if their pelvis is especially forward and they have a lot of posterior compression, what you can also see is all this anterior rib cage comes down, and then you're going to see this happen. So that's why, if you guys have measured wide ISAs taking this assessment lens, you'll often see them have really limited IR, but tons of ER. This is really easy. It's because of this right here. It's a secondary compensation. And it's mostly within the thorax. So we really haven't gotten to the pelvis quite yet. I think we got a chat message. Wouldn't anterior compression push backward? So think about it like this. I'm here, right? Ooh, not good. So here, I'm going to pull myself forward like this so I'm not leaning back so much. And then it's just a jigsaw puzzle from there. So if we're way back here, we got to come forward, and then we can more and better upright ourselves. Narrows are very similar, and you'll see why in a second. So it's all about going too far back, going too far forward. But I can see how you would think with the pelvic position, aren't they falling too far forward? Well, you can look at it that way, but look at what the thorax is doing, because this is a compensation that's happening within the thorax itself. And it's all connected. Yes. Now, what you would expect to see in this individual is internal rotation that's limited, but you're going to see external rotation that opens up. And that explains why so many wides. I can do this all day because I have a secondary compensation. Shoulder flexion is going to be very limited because they still have that posterior compression. They're still probably limited below the level of the scaps to some extent. And shoulder AD and abduction is going to be limited bilaterally, because if you remember, both of those things measure what is going on anteriorly and posteriorly. Now they've lost either the posterior or anterior aspect of those measurements. And this is, again, a general guideline. But when I see someone who has more ER than IR in their thorax and they're wide, then I know that this is going on. The third layer is now just the opposite. Now they're thinking that they're falling they feel like, for example, that might be a typo right there, too far forward. So they basically just compress themselves again and go into this sway back. And this is a pelvic orientation issue. So for example, think about someone who has sway back posture. You probably think of someone who's narrow, right? But like I said in the beginning, these people generally tend to look the same the further you go. So if I'm here originally, then I'm here, I'm running out of stuff to compress. So I need to compress my pelvis, and I need to seek a way to bring myself back in space again, because now this has brought me too far forward. So then I need to go back again. So what I'm going to do is I'm going to kick on my rectus abs. I'm going to seek an ability to bring my pelvis back in space. So I'm going to go sway back. And these people have a lot going on. You'll know these people when you see them, generally speaking. So they're going to bend their sacrum backwards. They're going to start to look like a narrow. And then this is an inhalation strategy. The last one was an exhalation strategy. Tipping back of the sacrum is more inhalation bias. So we call this an inhalation strategy. These people are going to have tight butt syndrome. They're going to have a ton of glute concentric orientation because of this exact thing happening right here. They're going to have supination at the ankles, and they're going to be clawing the ground with their toes a lot of the times because their foot is so inherently unstable. So these people, when you see a wide with super high arches, like a genuine wide with massive arches, they're probably in game, assuming they don't have something freaky going on within, maybe a crazy injury or something like that. They're going to have a toe off position in the feet, but again, still high arches. Now, because of this third layer of compensation, they're going to basically have a lot more ER than IR. So they're still going to be really compressed in their thorax because they're being squeezed from all directions at this point. They started off with more of that posterior compression in their thorax. Now it's coming from both directions. And their pelvis originally was biased towards more of this nutated state. And then that has its own compressions. And now you're going to pile on the compressions of basically what a narrow is. So now you're going to be bending that sacrum backwards. Literally, it bends backwards. I think there's an x-ray picture I can try and find for you guys of this actually happening. And it's pretty bizarre. It literally bends. It's quite interesting. Their supine knee to chest is going to be beyond 90 degrees. It's going to be way better than it was before because they've sought an inhalation strategy in order to bring in more external rotation and more of those expansion mechanics. And then their straight leg raise is going to be less than 45 degrees because remember what happens below 45 degrees, you have to be able to do this. You got to be able to nutate. So because they have all this compression in here, they can't do that anymore. So they're going to have a really limited straight leg raise. And their squat is still obviously not very good. You honestly might see these people have like a 70-degree squat in terms of hip flexion. That's what I mean by degrees here. Okay, narrow ISAs now. Narrow ISAs, we already know this, counter-nutation, inhalation strategy, but what happens when they start to compensate? Well, it's just the opposite of wides. So they could feel like they're falling too far forward. So what they need to do is they need to seek a strategy to get themselves to come back. So they're just going to compress themselves posteriorly, and their pelvis is going to go forward in space, and they're going to have an anterior pelvic orientation, not a relative issue a lot of the times. So if you kick on your back extensors and you're in this position right here, and you just get pushed forward, that's what's going to happen. So now that helps them pick up a little bit of internal rotation, at least within their femurs, but they're still not going to be able to nutate very well because this is an orientation thing. This is not them just going, okay, well, now I'm going to nutate and come forward. They're still here and it's being pushed forward. Now, within their thorax, because they started off originally anteriorly compressed and now they've compressed posteriorly, they're going to lose ER and they might pick up a little bit of IR just by nature of having their ribs flared up and chest puffed out, very similarly to this girl in the picture right here. But they're still starting off anteriorly compressed, so they're probably going to be limited in both IR and ER at the shoulder. So you're going to see usually ER limited up to about 80 degrees or less. IR is still going to be less than 70. Shoulder flexion is going to be less than 120 because of where their compression is posteriorly. And you're also going to see a squat that's usually less than 100 degrees because they can't roll their pelvis back underneath them again because this is being pushed forward. Sometimes they can do it and they just butt wink. So that's something to look out for. If you're narrow and you're in secondary compensation and you see them just like totally roll this thing under because they still have counter nutation, they just got to do the butt wink, then I would probably not count that as a squat, like the depth of that squat. I would stop where you see a severe butt wink. Keyword and significant butt wink. And then their active knee to chest is going to be less than 100 degrees for a similar reason why their squat is less than 100. Now the tertiary compensations, it's just, we're back to sway back. So this is very similar to the wide ISA third layer. Now they're falling too far forward, so they need to come back, at least within their pelvis. So what they're going to do here is they're just going to be compressed from all directions. Everything is now compressed. They have compression on the front and back side of their pelvis and front and back side of their thorax. So that's why sway back looks so janky right there on the right, because you have all these different layers of compression pushing you in and out. So they're going to bend their spine at T8 a lot of the times to create some semblance of ability to bring in air. And then that's why you see that sway back within the pelvis. And then up top, that helps them create some degree of inhalation strategy, but that's also going to kick on their rectus abs. And they're not going to be able to utilize their obliques very well. So this is very, very similar to what you see in a wide, which is kind of nice because then you can just treat them very similarly. So this is literally the exact same thing as the wide slide, because you're going to see these people, like people are people, you know what I mean? So people are ultimately going to compensate in similar strategies at the end because they're running out of options. And humans are different, but we're not that different. We still have our organs set up the same way. We still have 4 limbs and a spine that acts very similarly. So while there are individual differences, we're still human beings. So this might seem like it's a lot, and it can be a little bit overwhelming. And I totally understand that. And we're going to go through tons of case studies later on. We're going to talk about all this different stuff. So if you're a little bit confused right now, just know that that's normal, and know that we're going to get through this. We have a lot more time left in this course. So just stay patient and just understand that hardly anyone fits this bill perfectly. Those measurements I gave you guys for the compensations, that's what you usually see, but I can't promise you it's going to look like that every single time. The only way you can really maximize your ability to go through this stuff is just get reps with clients and get reps training people, because you're going to start to be able to just know where someone is without having to reference these sheets, which is really nice, but it's going to take a little bit of time. And it's really just about managing gravity. If you can manage gravity, then you're going to be able to be as efficient as you can possibly be. So it's important to understand this is just a battle to stay upright. And then if you understand where they're coming from, you know how we can get back to where they were. So that's why we spend so much time learning what the primary stuff is because that is where we want to get them. If we don't know where to get them, then we're going to be lost. But also, it's going to help us understand how they got there. So simply put, we want to restore expansion first within the pelvis. We want to restore external rotation in pretty much all cases, unless they're a narrow with primary compensations. And then we want to restore what they should have in the thorax. That's pretty much a giant summary of next week. So if they're wide, I want to give them internal rotation in the thorax back. If they're narrow, I want to give them external rotation in the thorax back. And then they start to look like their old selves again. Okay, now we're going to get into pelvic orientations. So again, I just want to preface this by saying this can be confusing, but just bear with me. We're going to get through it. You guys have some questions in your study guide that relates to this stuff. So usually, and I get a lot of this stuff I got from Alex Effer. So check his stuff out if you're interested in this. But we're going to spend a lot of time on these orientations because this is what you see with people who start to get crazy asymmetrical. Everything we talked about is a bilateral thing so far. It's happening on both sides. But what happens when we get so far asymmetrical? What happens when the left AIC, goes on steroids and then all of a sudden we're all over the place? Remember what I said the first week of we've been in our right side for so long, it starts to push back and we start to get into our left? These are instances like that. So usually what you see with these is the right hip starts to lose internal rotation. When the right hip starts to lose internal rotation, we're in trouble because the right hip really should have internal rotation. That's what we're relying on in our asymmetrical pattern. So these are usually, look at what happens with this. This is me getting internal rotation. This is me getting internal rotation. This is me getting internal rotation. That's why when you see a hip hike, when someone's walking like that, they're trying to find IR on that hip. So the first one we're going to talk about is a sagittal orientation. This is an orientation where you're being pushed pretty much like that. It's straightforward. The force is, at least, so you can think of it as a sagittal force, but ultimately it has a rotational outcome. You know what I mean? So these arrows are a little bit misleading because I didn't really know how to show the arrows coming directly at us. So think of it like the force is coming straight like this, which is going to push the left pelvis ahead of the right and also down just a little bit. So because of that, the left pelvis ends up in this sort of in-game state. It's basically the left side is just so locked up at this point. So they're trying to get back into their right hip, but they're still in this left toe off position because, well, the pelvis is very forward on that side, but also the right is originally biased towards this early mid stance. So the right's going to pretty much stay there. So if you know you have a sagittal orientation, this is what you're going to see in your measurements. You're going to see you're going to have a better straight leg raise on your left than you are on your right, as well as hip flexion. You might ask yourself, well, why is that? Well, think about it. If you push this way, then you're starting on the table like this. And then this becomes much easier because of where you're starting. If you guys watch that Bill Hartman video on mistakes people make when they interpret range of motion, you have to understand where they're starting on the table. So they're rolling, they're here. So this is much easier, but then that right hip is often going to pinch because it's going to get stuck within the acetabular rim because it's got nowhere to go. So it'll often pinch at 90 because it's totally jammed up. So because of that, their right internal and external rotation, you usually see it's a little bit better on the right than the left. The left is going to be about 20-ish degrees. And then the left shoulder flexion, abduction, and external rotation becomes better than the right, which is interesting. Not what you would expect in the left AIC pattern, but it's because of this sagittal orientation. So if you see these distinguishing features, and I would say you would probably need to see all of them because you'll see that as we go through the other two, there are similarities. I would say these boxes need to be checked before you're like, yeah, that's a sagittal orientation. The next one is a lateral orientation. Think of it like this. The force is doing this. So you are being pushed, you're doing a hip hike on the left, which often brings your shoulder down on the left too, which is interesting because you might think, well, if there's a hip hike, aren't we going to be like this? Well, you still have to have 2 feet on the ground. So what you're going to often see is this. And then that left shoulder comes forward because that pelvis is raised on the left, which brings all this together. So the back extensors, the QL, are going to be basically just bringing all this together. So you're going to have a left hip shift in a squat, which again, you don't see very often, but if you do see it, they're probably doing some sort of lateral orientation within their pelvis. They're going to have a bilateral late stance in their feet. And what you're also going to see within that squat a lot of the times, because if they're here, they just have more room to sink down on the left in that squat. So they're going to come down, and you also might see them shoot back to the right after that. Because if they're starting here, they're going to go down, and then they might shoot back like that. But the distinguishing feature to look for in that squat is what happens when they get to the bottom of the hole. The distinguishing features for this are going to be left hip internal rotation is better than the right. The left SLR, active knee to chest, is going to be better than the right too. And the right active knee to chest is going to be less than 90 degrees. Right straight leg raise is going to be less than 50 to 60 degrees, which is very limited. That's what you want to look out for there. The last one is a right oblique orientation. You can think of this one as the transverse push, because now you're coming here. Now you're doing this. So what you end up seeing is heel, strike, or mid stance on the right, and left late stance, very similar to what you're going to see in just a normal left AIC pattern. Now, this person's gonna have a right hip shift in the squat, because you can see how that would be more possible if you're on that oblique axis and orientation here, because you're being pushed over to the right in an attempt to find that right internal rotation. Now, I have someone who has this, and they measure very similarly to a left AIC. And that can be confusing because they still have this oblique issue. So I would say if you have someone who you think has one of these oblique issues or just any sort of pelvic orientation issue, don't freak out. Just clear them bilaterally. Just go through everything that you would normally do. And then a lot of times things take care of themselves. So just don't worry about it too much. We're going to get into it next week a lot more. And I know this stuff can be a lot. So just don't worry about it. It's actually not as bad as it seems a lot of the times. So the right straight leg raise, active knee to chest, hip IR is going to be better than the left. Left shoulder flexion is better than the right. Now, that first bullet point right there, that's what you would probably expect to see a lot in this left AIC pattern. But they're also going to have a better active knee to chest on the right, which is not what you would expect to see. On the left shoulder flexion, again, not what you would expect to see. So if you paid close attention, a lot of these things are pretty similar. So that's why we need to be very confident we have this before we start addressing it in the manner that we should. So we need to check these boxes. Make sure that you see all this stuff. Make sure you see all this stuff. And then you can say, okay, this person probably really does have an orientation issue. The last thing I wanted to talk about here is the right AIC. Now, I got a couple of questions. Why was that short right leg thing incorporated within that slide? I think it was week 2 that I put that in there. And that's because it is a deviation and what I consider a compensation from the left AIC pattern. Now, to be honest with you, this could be an oblique issue, or sorry, a orientation issue like we just discussed. This could be a lot of things. And to be honest with you, I don't have all the answers when it comes to this right AIC. As far as I'm aware, within PRI itself, they're still figuring this out to a slight degree. But what you'll often see is the opposite. And you don't actually, I shouldn't even say often see, because you really don't even see this that much. But if you do see this and someone appears to be completely flip-flopped in terms of their measurements, in terms of what you would expect, then it's not all that different from these oblique orientations or these different pelvic orientations. What you want to do is just clear them bilaterally. And then if they still have a ton of stuff going on, and they still have a ton of asymmetries that lead you to believe they're in a completely backwards pattern, then give them a right side first. And this is honestly a pretty good strategy for if you're ever extremely confused with someone. If nothing makes sense and you're really struggling with someone, give them a right side first, because that's going to bring them back to where a left AIC should be. So if you clear all the stuff as much as you can, and you're like, oh man, I don't know what to do anymore, give them a right side first. And usually that helps reset them to some extent. So all of those exercises we talked about in week 2 and 3, take those, do them the exact opposite, and you're probably going to be in a pretty good spot, because they're going to reset them back to that left AIC. The only time we wouldn't do that is if that individual was born with their organs flipped in their body, which does happen. And at that point, that's probably beyond most of our scope of practice. And we should be collaborating with someone who's qualified to handle that. Okay, now local compensation patterns. Now we're going to get into a little bit more of isolated stuff. So just to review, this was in week 2, but I want to review it again because I still use this foot assessment all the time. I don't think it's necessary for you guys right out of the gate, but I think it's something that's going to really help you in terms of your lens. So this is what I consider optional, but also something good to keep in mind. So again, if someone's biased towards heel strike within their feet, what you're going to see is this big toe gap. You're going to see the femur turned into relative IR and the tibia turned down to relative ER. And you're also going to see a relatively high arch. If someone's biased towards mid stance, you're going to see the distal femur relatively in ER and the tibia turned into IR. Both are biased towards IR, but the distal femur is relatively in ER. The big toe is going to be mostly straight ahead, and they're going to have pretty pronated feet. You're not going to see anything too crazy in terms of what their foot is doing because it's just pretty straightforward. And then within late stance, the femur is going to be turned in and you're going to see the tibia turn out. The only way that can happen is if they're in late stance, because what they're trying to do is be in late stance, but they can't do that because they can't just literally go on their tiptoes. I mean, it can, but you just don't see that. So big toe is going to hug the second toe and it's going to turn out, which you can see is starting to happen more so on this guy's left foot. And you're also probably going to see a slight degree of an arch. I would say this gentleman right here is probably biased towards late mid stance, late mid stance, early toe off ish. He's transitioning. But these pictures were actually taken when he was actually starting to make some progress, which is why he's more mid stance ish now. This is Kyle Woff, and you guys know him. Knee extension is a way we can also determine what's going on within the femur. So if we fully extend our knee to 180 degrees, then we know that we have the ability to internally rotate our femur, externally rotate our tibia. Opposite for knee flexion. 130 degrees is what we're looking for here for femoral ER, tibial IR. Okay, with that out of the way, so I call the first part of this knee pain sagittal issues, even though this is far from sagittal. It's just what most people think of when they think of, sagittal knee issues like hyperextension, for example. So someone's pelvis is really far forward, then you can see two things generally happen. If their pelvis is anteriorly oriented, then you might see someone excessively lock out their knees in an attempt to find their weight more on their midfoot. But what you actually see more often than that is an external rotation bias. So really, knee hyperextension is an external rotation thing. So the femur goes into ER, and then the tibia often follows it into ER to some extent. So there actually becomes this huge external rotation bias. So the lateral hamstrings start to become very concentrically oriented, like the biceps femoris. But then the internal rotation fibers of the hamstrings, like the semitendinosus, um, or the I always forget which one does internal rotation, but the more medial hamstring is going to be weaker here. So we need that hamstring actually in a knee flexed position to bring this pelvis back to a more neutral state to allow for them to access internal rotation. We actually got a question this morning from Amy that was exactly on this. So good timing. Sway back is going to be a little bit of the opposite of that. Now, this, again, if they have sway back, then they have a ton of stuff going on. They're probably end game, tertiary layer. Don't even worry about this knee stuff because they're probably going to have a lot more pain going on than just that. So unwind them, start doing the stuff we're going to talk about next week, and just understand that they're going to have so much going on. We just want to make sure that we can clear them bilaterally first. And then you'll probably see them start to orient towards either too much ER, or you'll see that it just goes away on its own. Medial knee pain, inner knee pain. So what you often see here is usually you see this in narrows, and you're going to see an anteriorly tipped ilium a lot of the times, but the big key here is the femur is going to be in relative IR and the tibia is going to turn out into ER. So that's what's going to stress the inner knee here because you have torque going on within your knee. Your femur and tibia are trying to do two totally different things. This is also this femoral internal rotation, tibial external rotation. This is just knee valgus. When it starts to get really crazy, this femoral IR, tibial ER, you see those knees cave in. Within lateral knee pain, you're going to see a posterior orientation of that ilium in most cases. And you're going to see the tibia start to go into a lot of external rotation alongside with the femur. So everything's going into ER here. Now, if you pay attention to that image on the right, you can see that as that bowstring force is pulling that kneecap laterally, you're going to have a lot of stress within the lateral compartment. So therefore, you're going to see a lot of lateral knee and thigh pain in people who have a big external rotation bias. And that's going to be influenced by their Q angle. So look at that angle right there within their pelvis. And as that angle gets wider, they're going to have more of a hip ER bias in most cases because Q angle is greater in females and females tend to be more narrow. And therefore, the wider this is, the more you're going to have that external rotation bias. And then if that tibia follows it out a lot, then that kneecap gets pulled. Within someone's foot position, you're usually going to see a late stance bias within their feet. You're usually going to see this kneecap. If you look at these two knees right here, and then compare that to what you see right here on this image on the right. You guys kind of see that, right? This is being pulled laterally. Especially this knee right here, you can see that happening. That left knee, it's being pulled laterally. So usually these people are going to have that late stance bias. And obviously they're there because their big toes are still relatively sprayed out. They're in tibial ER for sure. And they have an arch. Lateral ankle sprain. So ankle sprains, once you start getting into this stuff, you start getting, I don't know, like a lot of us are strength coaches and personal trainers. Are we really qualified to rehab an ankle sprain from the beginning? Probably not, but just make sure you're working alongside of PT as well, is all I'm trying to say. So if you have an external rotation bias, then you're going to have this ankle supination, or you should in normal circumstances. So what's interesting about lateral ankle sprains is it's so easy for you to do it over and over and over again. I think when I was digging into the research on this, I saw that there was, I believe, a 33% chance for you to re-sprain your foot if you've had a lateral ankle sprain in the past, which are pretty shitty odds. Because imagine if you broke your arm and someone told you, hey, you have a 33% chance to break your arm again. And it's just like, oh, great. Like you'd be upset. I would be upset. So this is a pretty important thing to consider. And basically what's going to happen is they're going to have an increase in ground reaction and supination torque when they strike the ground heel strike. So what they're going to do is they're going to roll on their ankle even more when they hit the ground. Let me see if I can find my foot model. They're just going to do this. They're going to roll even more on that foot because it's probably weak and it hasn't actually regained the pronation mechanics. So this person really needs to learn how to pronate their foot because they're just going to keep overly supinating until they sprain that ankle again. And most of these sprains occur at these 3 ligaments right here. Just think of a basketball player rolling their ankle. Medial ankle sprains are more rare, but they still do happen. A lot of the times, tibia is in internal rotation, you get a pronated foot, and then if you roll it in, then you're going to strain those ligaments on the medial foot. Now, that's not always how it happens. A lot of times ankle sprains are just, not great luck. Sometimes you take a step off of a curb the wrong way and it's not your biomechanics. You just got shafted by nature or whatever. So ultimately, I think these things do matter, but ankle sprains are so, circumstantial based. Elbow pain. This is an important slide. I hope you guys pay attention to this one when you go back and review this stuff, because the elbow is just the knee. And the more you look at the elbow, the more you realize it's literally just the knee, because we used to walk on all fours. We used to be, animals that were quadruped. So we literally used to use this arm as a leg at one point. So because of that, they operate very, very similarly. You're going to see humeral internal rotation in this valgus position, and you're going to see forearm external rotation, which is just knee valgus, because knee valgus is femoral internal rotation, tibial external rotation. So it's very, very similar, and they operate in a surprisingly, remarkably similar fashion, which helps us then understand and how to basically treat an elbow like a knee. You're going to have a good outcome. But it's going to start at the rib cage. And we've got to appreciate that it starts at the rib cage, because if we're just looking at the elbow or just looking at the shoulder, then that's not good enough, because the scapula rests on the shoulder and it's got to be able to glide, which allows the humerus to move, which then allows the forearm to move. Now, if you guys look on this image on the right here, you're going to see what usually happens in most people within the left AIC pattern. The right arm is biased towards pronation. We call that internal rotation too. And then the right forearm comes out into supination and external rotation. So what do you have there? You have that valgus on the right. On the left, you have the opposite. You have more of an ER bias on the left side and more of a internal rotation, pronation bias at the left forearm. We call that varus, just the opposite of valgus. You can use these pronation and supination tests to see what's going on in particular. I don't use these a ton because I just look at what's going on within the humerus itself, and that usually gives me a pretty good indication. But you can stabilize your elbow and then turn outwards. If they're missing supination, then you know that they have an external rotation bias at the humerus. If they're missing forearm pronation 70 degrees, then we know they have an internal rotation bias at the humerus. So this is just a good little way to check what you're doing. And if you're really confused on someone, you can use this as a tool. Neck pain is tricky, and my mouth is really dry. I'm going to take a... Neck pain is very tricky a lot of the times because these people are often very unhappy, and understandably so. Like, you guys ever had neck pain before? It sucks. It really like, you feel like you're choking. So imagine you're walking into, a personal trainer's facility and you feel like you can't breathe and you're choking. You're probably not having a very good day. So I think it's very important to be sympathetic with these people. And I think it's very important to make sure that they can relax, because everything is a threat to them. And everything is a threat to their ability to breathe, which they're already really struggling with. So what's happening is the diaphragm can't work. So a lot of times these accessory muscles of inhalation are going to kick on, which is going to elevate the first 2 ribs And then you're going to have a situation where the neck is going into overdrive. If they feel really tense in any position, I will cue some relaxing music, which sounds kind of crazy, but it's really actually helpful for these people. Get them in sideline, put a pillow underneath their head, sideline 90-90, and then just have them chill and relax and breathe. And that can go a long way. Make sure they're keeping their shoulders out of their ears. I would just say side lying is a massively important position for these people who have neck pain. I would not put these people in supine positions because they're probably going to struggle to inhale because gravity is compressing their chest wall. Quadruped can be okay, depending on if they're wide or narrow, probably better for narrow. And standing is also probably another position I would use for these people. And we'll talk all about that stuff next week. Okay, so to summarize everything in this presentation, worry less about the symptoms and more about the objective test results. I made the mistake early on with this stuff of listening to, like really intently listening, which you should do, to what they were saying about their symptoms. And I would get very anxious and overwhelmed because I'm trying to solve the symptom and I'm not just going off of my objective measures, because I'm going to give you guys the tools to improve your objective measures. But if you sit there and listen to the fact that, you know, their right fingernail hurts on their thumb, and like their big toe points out this way and their neck is cranked that way, and like everything hurts, then it's overwhelming. So just go through the objective results, and that stuff is going to lead you a long way. Because in my experience at least, and I know I'm not the most experienced practitioner in the world, but at least from what I've seen, I've never seen someone that's in a dramatic amount of pain, or even just really any pain at all, that passes all the tests. I've never really seen that, unless they're really eccentric. And you guys probably know what that looks like. Remove the layers of compensation first. This is just the superficial muscle principle. So if we get rid of the big boys that are basically choking us, or the big boys that are compressing our rib cage, or our big glutes that are pushing us forward, then we need to shut those off first, and we can then get to the stuff underneath the surface. And then everyone will show asymmetries to some degree. I've never seen one person that has perfectly symmetrical test measures on both sides with everything. So you're going to see a lot of things. You're going to see like a secondary wide or narrow that looks, wow, you kind of look like a left AIC, but they're not, because all their measures are really not great. So just because someone's highly asymmetrical does not mean we should treat them asymmetrical right out of the gate. In fact, I think that would probably be a mistake. Clear them bilaterally as much as possible before worrying about pelvic orientations or asymmetries. That's the most important thing. I pretty much just discussed that. Okay, so I know we did an assessment last week, and the reason why we did, and hopefully you wrote it down and still have it, is because now we're going to see if you have a compensation. So let's just run through a quick assessment. If you haven't, now's your chance to write down where you are, and we'll discuss what we see. I think this is going to be a very, very beneficial exercise for everyone involved here. So let's all go through an assessment. I'll walk you through it. First things first, we're going to do our squat. So toes straight ahead, feet hip width apart, and let's see what you guys got. Pay attention to how deep you can get, and then write down the degrees of hip flexion that you got. If you get asked to grass, I would just say full. We have a lot of good squatters in here. After that, do your toe touch. Toes straight ahead, feet hip width apart, and then, thanks, Kevin, and try and touch your toes. See where you get. If you get to mid shin, you can nutate. Can't counter nutate. If you get all the way to your toes, that means you can re-counter nutate, unless your thorax looks like you're just totally bent over. So Amy, yours is a good example of someone who has very long hamstrings. You have a great example of that. Everyone, if they look at Amy, She's just bypassing everything because she has very long hamstrings, which is normal for what she does. Again, is it a problem? Probably not. She does this for a living. Okay. Let's go on the floor and let's do shoulder flexion. So you can either reach your arms down, keep them locked out, or you can do the bent elbow variation. I've been more partial to the straight arm variation. Just make sure that that elbow's staying straight ahead, and make sure that you're not cheating and letting that elbow turn out or the elbow bend if you're keeping your arms straight. Looking good. Record that, and then also make sure that palm is staying perfectly straight up. Or I mean, sorry, start in that anatomical position, meaning that your, yes, palm is facing straight towards the ceiling at the beginning, and then it's going to face towards the ground as you get overhead more. And another thing on the shoulder flexion thing that I've been cueing my clients a lot is make sure that you can go really, really slow. People will just fly through this and they'll try to just fling their arm up and they bypass it. So I say like as slow, like way slower than you think you need to go, because I can start to feel the restriction for me right there, or I can just fling my arm overhead and it's really easy. All right, let's do active knee to chest now. It's good if you can put your feet up against the wall here. And then make sure you pin that other hamstring down and just move at that knee. Nice. Amy's got a ton of range of motion. Ryan's looking good. Ben looks like me. And Ryan looks like, yeah, nice job, Ryan. Ryan, you're a good example because you're just like the most standard narrow, just in terms of like your frame and who you are. So that's a good example right there.
I'm glad that lines up with what I've been seeing.
Let's do straight leg raise. Make sure you're recording this because I want to find someone who's got some crazy stuff going on. I'm sure we got someone. Ooh, Ryan Sandman. That's a great example right there. Ryan, can we use you? Yeah, check out Ryan Sandman right there. He's got like a 30-degree straight leg raise, tons of posterior compression, and he's also definitely a narrow. So check that out. That's a great example. I'm curious to see what the rest of his assessment looks like. Okay, now let's go shoulder internal and external rotation. Then record that. And then after that, let's go shoulder AD and abduction. Make sure with that adduction, you're keeping that posterior shoulder pinned on the ground. Okay. All good? All right. What did we have? Does anyone think that they had a third layer? Let's start there. Did anyone think that they were end game? Ryan Sandman, what do you think you were? Can you read off your, would you mind reading off your full assessment?
Yeah, is it easier just to say it really quickly?
That'd be awesome.
Squat, I can get all the way down. Toe touch mid shin. Shoulder flexion, I'm around 120 on both. My right is a little bit better than left. Supine knee to chest is pretty good, close to 120 on both. Right's a little bit better. Active straight leg raise sucks on both sides. Right IR is pretty bad in my shoulder. And left IR isn't great. It's better. And I almost have total ER on both, but right's a little bit worse. Adduction is okay. I haven't gotten abduction yet.
What would you guys say he is? Anyone have a thought? I would say, Ryan, that you seem like you're honestly pretty standard narrow. It sounds like. I just think you have quite a bit posterior compression within your pelvis. So I think that honestly, your whole situation isn't too concerning. Do you have any issues? Do you have any pain or anything?
I've had a lot of back pain in the past, and like a couple back injuries, but I've been kind of studying this stuff for a while, and I've been getting better at it. I was told I have a superior T4. I don't know if you can get that from the measurements or not, though.
Yeah, so superior T4, the right shoulder is usually lower, right? So when PRI says the right shoulder is higher, what's generally happening is the right scalene is trying to elevate the right anterior rib cage to get air into it so that you can actually get the expansion, because that right chest wall is often so compressed. So that would actually make sense. The only thing that stuck out to me in terms of your asymmetries was that your right ER was worse than your left. Is that what you said?
They're both pretty even. I think right was it was like barely better, like a few degrees better.
Okay, gotcha. And what was your, if you were to put a number on it with your internal rotation and adduction, what would you say?
Internal rotation was maybe like 55 or so on the right, and pretty close to 70 on the left. Did you say AD or AB?
AD.
I couldn't notice anything side to side. I thought they were both pretty good.
You felt like you had pretty full range of motion?
I thought so. It seemed like maybe my left shoulder was coming off the ground, but it was hard for me to tell.
Okay, cool. Yeah, so I think you might have some degree of that superior T4 going on, but I don't think your case is particularly concerning. Does anyone think they're deeper in their compensation pattern than Ryan? Anyone at all? Nope.
I think I'm kind of messed up.
Yeah? What are you, Jonathan?
So, I mean, I believe I'm a wide.
Okay.
To start out, I can get in a full squat. I can touch my toes, which might be compensatory. I might have a strategy to get there. So like knee to chest. I played soccer all my life. I have hip issues. So that I get the pinching around 100 degrees. In terms of what's up?
On both sides?
Yeah, right's worse, but definitely like I feel it on the knee to chest. Straight leg raise isn't great. So
what would you put for a number?
Maybe around 70.
That's pretty much what we're looking for.
Okay. It just doesn't feel great, maybe.
Yeah.
But then in terms of upper body, so very little IR on both sides. And then the big thing is, so anything adduction, and I've had this all my life, it feels like both shoulders are going to pop forward. And I know I had the question a couple weeks ago, even though I'm a wide, my scaps wing. So I've always had the issues of shoulders popping out, which I eventually kind of trained out of, maybe improperly. But so I've always had like shoulder issues, I guess, whether it's like throwing or something like that. But they're like I guess pretty loose. So and that seemed not to be like the right compensation based on what you said between like wide and narrow to having the wing scaps. But
What
that's
makes
why
you say you're wide? I'm just curious.
I feel like I have a wide ISA. Right. From what I've seen.
Fair.
Yeah.
Good answer. Good answer. Could you stand up and show us your ISA? I'm curious what it looks like. You don't have to take your shirt off or anything. Just yeah, you are pretty wide. It looks like. Now, would you mind laying on the ground and measuring it there? You don't have to move the camera or anything. Just say if you think it's over or under 100 degrees. Because usually if you lay someone on the ground, their ISA actually shrinks. Standing up can be a little bit misleading sometimes.
I still think it's wide.
Yeah? Okay.
Yeah.
Can we see your squat?
Yeah.
That's a great squat. So here's the deal. I think, Jonathan, and I could be wrong here because I haven't assessed you, I haven't looked at you, but show me what do your collarbones look like? I'm just curious. Are they pretty flat or are they on an angle?
I can't tell.
Put like try and like draw on them a little bit because I can't really tell. It looks like they're on a slight angle, would you say?
Relative to what?
Relative to being just like a straight line. Like my collarbones are very flat, I would say.
Slight angle.
Slight angle, yeah. I think you might be a narrow who has sought a compensatory strategy. And you see this sometimes, their ISA widens out, but you also could be a wide who's heavily compensatory as well. But honestly, I don't think it really matters because we would probably treat you the same either way. Because again, if you get, the further along you get in this compensatory pattern chain, the more similar these people start to look. So does anyone have any thoughts on his assessment and where he might be within the layers of compensation?
Question, for Jonathan, would you still restore wide ISA like normal rib cage mechanics?
I probably would put him in a quadruped position to start so he can get some IR back.
Okay.
So you think there's more anterior compression?
If you've got a lot of limitations in IR, I'd say, yeah. Can you remind me what your hip flexion was?
Hip flexion, it was probably around 100.
100? Yeah.
Mm-hmm.
Yeah. I would probably, because your squat was so good.
I've also been working on that for like a year, by the way.
Yeah. Your squat?
Yeah.
Nice. Yeah. I mean, it looks really good.
Nice.
So I think you might be missing hip extension because your hip flexion in your squat is completely fine. Like it's clearly not an issue, but you really struggle in the supine variation to keep your other hamstring pinned as you bring the other leg back.
Mm.
Do you feel like if you lifted your other hamstring up, you'd be able to bring the other leg back further?
Probably, yeah.
Yeah, I think it might be a hip extension thing in that circumstance.
Okay.
So I would say, go ahead.
I was saying, but in terms of like, because what's really significant in terms of like the winging and just like my shoulder blades can go all over the place. And then for the longest time, probably because I didn't know, I have a better understanding of the biomechanics of it. That space between the shoulder blades, like, traps, rhomboids, like that never filled in on me because that was just like a divot. Does that make sense?
I totally understand what you mean. Is your ER pretty good?
That just falls right back.
I think you probably need anterior expansion. Yeah. Whenever I address a wing scap, and like that's like really what that person wants to fix.
Mm-hmm.
And I think you're probably being pulled forward by tight pecs and all this is coming forward. So we need to get you to breathe here so that this can come back and you can expand all of this. So I would probably put you in a quadruped position. I think that's probably the best place to start you.
Cool.
And we'll talk about that a lot more next week.
Awesome. Thanks.
Of course. Anything else in terms of assessments? Anything stick out to you guys within your own? Tyler, how was yours? Tyler,
Me?
well, yeah, how was yours?
Oh, mine was good. I had a huge difference between shoulder flexion on my left side versus my right, like big time. And that's like, I mean, I'm pretty pain free, but I do have like some left shoulder, left hip stuff that, I mean, isn't as good as my right side. So yeah, I noticed a huge difference like when I do my single leg straight leg or single leg raise. If I like, that's about it until I have to start to bend. But if I let myself have that, then I can go way further. So, like, I don't know what you would call that, maybe like 55, 60 degrees or something.
I'd say you're probably above 60 there. Can you try one more time to keep your leg perfectly straight? It looks like you're having a hard time keeping that leg 100% locked out.
Yeah, I do. Even just like here.
Right about there. I'd call that, yeah, you're just breaking 45 there. Probably like 50-ish.
And then right side is higher.
Yep.
Yeah.
You narrow?
I don't think so. I think wide, but I'm not exactly sure. It's probably close to, but I don't know if it's because I've done a lot of the exhale training lately to bring that in. But if I'm kneeling, can you see my lighting's kind of
Yeah,
shitty.
sure.
Those are the ribs. There.
Yeah, can you show us your hip flexion?
Yeah. So I want to ask too, do you tell people to like posteriorly tilt or just leave a little?
Yeah, I let them get in whatever's comfortable.
So there's left, and I feel like it's like a 1 out of 10, kind of just not pinching, but tightness in the front of it.
All right.
And then right side.
So that would be a goal for us. We would probably want to seek to allow him to restore that. That would be something I'd want to go after. And what does your squat look like?
Squats fine. It's always been something that I've really worked on.
Yeah, that's not bad at all. Nice. So again, you might have a hip extension thing.
I think I do. When you were saying that last time, I was like, yeah, my hip extension, I think kind of sucks, to be honest with you.
Yeah. I mean, most people's is not optimal for sure. So I think restoring that would be a good first step for you.
Okay. And I remember when I reached out to you, because I said I did the AFIR stuff on my left leg, and I was like, it looked really messed up my hip because I was just pushing it further to where it didn't want to be. So sometimes it's kind of been flaring up, and I found that if I did like I don't know, think about like a prone cobra type thing, but then you're actively lifting your legs too, so you're in like Superman, I don't know, whatever they call it. But I put a band around my legs and did a little bit of like abduction as I extended through the hip, and then actually like felt pretty good. So yeah, I think more hip extension.
Yeah. For sure. Yeah. I think that'd be a good thing to do for sure. And just probably hamstrings out of the gate would be a good call for you.
Yeah. Okay.
Anything else you guys want to talk with your own assessments?
I got a question, Connor.
Yeah.
Pretty normal, but so I'm good at the knee to chest and squat, but I'm terrible at the straight leg raise and the toe touch. But so I get the mid shin on my toe touch, and that means that I can't counter nutate to get to the bottom, but then I can do that on the squat. So what would you like say on that?
Can I see it?
Yeah.
Okay.
So which one first?
Let's do squat, then go into the toe touch.
Here, squat.
All right.
And then toe touch, I'm pretty straight. It's like maybe like here.
Yeah. I think your squat, your hip flexion, actually you get stuck. I don't think you get to the point where you're fully recounter-nutating in your squat. Like go hang out in that bottom position of the squat one more time. You see how your hip flexion is like, you're just breaking 90 there. So I think while your squat looks good, and that would be an advantageous position for someone like a power lifter to squat in, I think that you're not fully recounter-nutating in that squat.
Interesting. I have done a lot of squats in the past, which like powerlifting style. So that might be why.
I bet you if you spent a little bit of time trying to get that back though, you would be totally fine. Like right there. See, you just dropped even deeper, but I still think you're not fully there.
Okay. So like, what would you do for someone there? Because I know it's pretty normal narrow, or not normal narrow, but you see that sometimes. So what strategies do you like work on that?
One of the YouTube video I just put out on restoring the squat, honestly, I get so much bang for your buck doing like that front foot elevated Jefferson split squat right here. Just going down, breathing in here, then coming back, something like that. It's one of my go-to hip flexion restoration techniques.
Okay. Do you think it's because like in a powerlifting squat, because every time I'm doing it, I'm in, at least like until like the last few years, it's like you're in shoes, you're in squat shoes with heel elevated, you have your toes pointed out, you're like really keeping a big arch lumbar. So like you're getting a squat, but it's not the same as like the pelvic position is probably different, right?
For sure. Yeah. And usually like people go knees out all the time because that helps them find internal rotation. So for example, like start here, you go down, and then you need to press your knees outward, usually at this position. So they're trying to find internal rotation at that position. That's why the knees out cue is so effective for many powerlifters, is because they're already biased because of their pelvic position. They can't fully access that IR efficiently. So they're trying to find IR through what we would think of as ER.
So like maybe more of the narrow stance, like the single leg loading stuff where you have like more of a neutral or even like a less arched spine. That would be helpful. And then getting hip flexion that way versus like in a squat where you're driving the knees out and you're like staying compressed there.
Yeah.
Cool. Thanks.
I have a question.
Yeah.
Really quick. So so because I can like go down really, really far in my toe touch, and I like more like, it's not just like I palm the ground, just like my elbows like go to the ground. But if it's overly eccentric hamstrings, and like I deadlift all the time, every single day. I do it. I am like at that barbell. I am deadlift. I'm doing single leg deadlifts. I'm doing like RDL, like my toes are elevated. Like I'm trying to do everything I can to like get them in a place where it's like, they're not so in that eccentric, like chronic state.
Yeah. I mean, what's your goal? You know what I mean? You're someone, how much do you do yoga every day too? That would be another question I have.
You know what? I actually, like the days that I practice yoga, I don't do it on the days in which I'm lifting too. It's actually kind of it's just not smart to do, because they're two totally different things. Like one, you are trying to be expansive. The other one, you are compressing. And I've noticed if I've done like yoga before I've lifted, then the next day I'm in a lot of pain and discomfort. But what actually works better is if I lift first and then I practice yoga. But however, it has to be like a shorter practice. I'm going to do like an hour and a half, like full out like vinyasa practice. It has to be on a day in which I'm not lifting at all.
Yeah, I think Jonathan just put something in the chat. Wouldn't RDLs, DLs be more eccentric bias? What about hand curls? So I think, well, a couple things. I think, Amy, you haven't been doing this stuff for as long as you've been doing yoga and practicing that. Sounds like you've been doing that for a lot of your life. Correct me if I'm wrong.
Yeah, I mean, like, as far as like being like in sports that favor like flexibility, like figure skating and like cheerleading and like, but I've also like, I started like strength training when I began cheerleading, which was like in my junior year of high school and continued through college. So, but I didn't start having like a regular like yoga practice until probably until like about, I would say like 12 years ago.
Okay. Yeah. So I think because you're narrow, and Pat Davidson has talked about this before, and like it's not a proven fact, I think, but I think it's supported by some literature. The amount of flexibility that you have as you end puberty is like what's available to you for the rest of your life. So for example, me, I was never flexible. So because like these like we get myelinated axons, we basically just lock ourselves into a position at the end of puberty that is like, we are no longer as nimble as we once were. We are no longer solidifying ourselves as much as we once were. So it's hard for someone like me to increase my flexibility because I never really had it. Whereas you, on the other hand, I feel like because you're narrow and because you're genetically predisposed towards being someone who's flexible, you have that mobility. And then that's your bias. So you still do that stuff and you're still doing what you're good at. And the strength training stuff helps, but ultimately you still have all this crazy mobility because either you were there at the end of puberty or you just kept doing that stuff through until like right now, which you're still doing. And I think it's fine because that's what you need to do. And I think if you became a lot more compressed, you might not be as good at yoga as you might want to be. So I think you're doing a good job of managing things. I think you're doing a good job of keeping yourself balanced. But ultimately, I think you're always going to be on that end of the spectrum because that's just who you are. And I think that's totally fine. I don't think that's there. You should seek to correct yourself out of that necessarily. But to answer the question of RDLs being eccentrically biased, yes, I think regular deadlifts from the floor are more concentrically biased, but I think RDLs are more eccentrically. And yes, hamstring curls can also be a good way of doing that. Something you might want to try, Amy. Do you have sliders or TRX?
Yes.
You can just place a ball between your knees and you can just go through slow, controlled hamstring curls, focusing on the concentric. So that's what I would do. And that's going to help open up your pelvic outlet or really close it because you're so far here. That's going to help you find this more. And that's going to help you find some internal rotation and some medial hamstrings, which I think would be beneficial for you.
Okay.
That was a long-winded question or answer. I hope that answers your question.
It's super helpful. No, because like I want to protect myself because of all of the years of just like pushing myself into like I used to teach like 14 classes like a week.
Yeah.
And in the past, like since I started doing a lot more strength training in like the past 3 years of becoming a trainer, like I've just made a very, very concerted effort to just protect like my joints, protect like the ligaments and all that stuff that I have just pushed myself to overly extend, to hyperextend, to be hypermobile.
Mm-hmm.
Well, and like so far, like it's been helping. I think that's what all like especially all yogis need, is they need to balance their practice with strength training. I've told other teachers this. I've said that strength training is a completion of your practice. But yeah, I mean, I believe so because it's about protecting your own body from overly extending, from being overly like stretching that ligament tissue. But also, you know, there's there's this tendency for like, if you go on like Instagram, you see like all these like yogis, putting themselves in all these kinds of like crazy stuff. Well, yeah, that's great. But if you actually like study that alignment, they're achieving that alignment by sitting in their joints.
Oh yeah.
Or sitting in their, and it's not supported by muscular action.
Mm-hmm. I know what you.
Yeah, and but the yoga community has yet to embrace like strength training as a viable incorporation into the practice.
Mm-hmm. See, that's what I think is so cool about this stuff, is that relatively speaking, no one is doing it or really knows about it necessarily. So you could take this information and apply it to anything that has to do with fitness. Like you could go, I know some people that are going the golf route. I know some people that are going like the special forces route. I know some people that are going, I don't know, like you could do cross country skiing. I don't know. But it's just, you can take this stuff and apply it to anything and you can have a niche. So for you, you can take it to yoga and you can introduce these principles through yoga or whatever you want to do. And then you're suddenly someone with a very unique skill set. At least that's how I look at it. I look at it as an opportunity in that sense. So you could be the person that helps bridge that gap, or you could do that within your training. So I think if you were my client, I would probably have you do very controlled ranges of motion. And I would have you do things like ball between the knees, tempo goblet squat to a 90-degree box kind of thing. I would have you really maximize the ability to really compress and control your range of motion, like that kind of stuff, which I think that rings a bell for like things you could do to really promote that. More hinge type activities are going to be important for you.
Okay.
Mm-hmm.
Cool. This is a funny thing. I had a consult with a yoga teacher who is interested in strength training, and I was trying to explain to her, what a narrow ISA is, and she said this is what she said. This is how like poorly like most yoga teacher trainings are like equipped with teaching biomechanics and science basically and anatomy. She said to me, she says, well, if I just did poses to open up my heart chakra, wouldn't that make my ISA less narrow? And I just was like, it doesn't really work that way.
I don't know. I've actually never, it's once you start getting down that rabbit hole of like, opening things up through just like sheer force, like sheer eccentric force, you know what I mean? Like, I don't really know, to be honest with you. I've never seen someone go at it with that kind of goal. I'd be interested to see what happens.
You know what a chakra is? Like a chakra energies, like the chakra system like has to do with like what's called the subtle body, which is not the physical body. It's like where you have like these energetic centers like down the length of your spine.
So she's talking like totally metaphysical right now. Nothing like, yeah. I see.
Yeah, and I said, well, having knowledge of the subtle body is important, but however, that's not going to impact or the structure of your rib cage.
Mm-hmm. Yeah, for sure. Yeah. I thought you meant like literally stretch out wherever that might be.
No. The heart chakra is like the place where you experience like openness in the world and connection to like other people. And yeah, it's important to like know what the subtle body like does. And like you have like your root chakra, which is like your sense of like grounding. Second, which is like your like creative sexual energy, and then you have it's a very metaphysical thing that's kind of it's really hard to get yogis out of.
I hear you. Yeah, that's just what they like to do. You know what I mean? And I think it's okay to let people, have their cake and eat it too. But ultimately, I think, just getting them, I think pain's a great motivator. So if they're not in pain, whatever, but if they are, then a perspective shift can be helpful. I have to go in a couple of minutes. Does anyone else have a final question?
Quick one. Hopefully it's a simple one. You're saying for, I get the kind of exercises to help hip flexion, so going into having the raised foot in the deep squat. What about for hip extension? So you're saying for Tyler to work on hip extension, is that a deadlift movement?
So if I've got a narrow And I'm probably not going to give them hip extension through the glutes because they're already biased towards using their glutes. So I probably want them to get more proximal hamstrings for hip extension and put them in positions where they can just be in hip extension. An example of that would be like here, I'll literally pull up an exercise. Something like an armbar variation where they're laying on the ground and they're going into hip flexion actively while keeping the other leg pinned. So like, I use this variation. Oh, geez. Okay, this will work. All right. Something like this activity right here.
Lay flat on.
Something like that is going to train hip extension on the down leg, hip flexion on the up leg right there. We're going to see this one next week for sure. That is one way you can train hip extension, but also you gotta, have the muscular integration as well. So I am going to do things like proximal hamstrings. For wides, I might consider using glutes a little bit more. So I might put them up against, let me think here. Something like this, it can be very beneficial for a wide. See what I'm saying?
Yeah. Cool. Yeah. I think I'm losing myself in the weight room alternative as opposed to the corrective aspect to work on beforehand. That's where I'm going with my head. So it's the bit in between.
Yeah, no, that's a good point for the weight room stuff. I would say, yeah, things that are going to allow them to access that full hip extension. So like single leg deadlifts, for example, single leg squat variations. Those are all going to be great, but make sure you're not doing like a front foot elevated squat on that side necessarily, because they're not going to be able to access that full hip extension. If your primary goal is hip extension.
Yeah.
Mm-hmm.
Cheers.
Anything else, guys? Okie doke. Well, I will talk to you guys. Oh, review session. I'm going to post a link. It's either going to be tomorrow or the next day because I'm doing PRI advanced integration this week. So keep a lookout for that message in the Slack chat right after this. Thank you, guys.
Thanks, Connor.
See you later.